So let's turn now to the BCL2 inhibitor that we have, Venetoclax. Discuss for us your experience in the clinical trial data for Venetoclax in the relapsed-refractory setting.
Sure. The relapsed refractory setting, Venetoclax use was very, very well documented in the Murano study, who really compared Rituxan Venetoclax against bendamustine Rituxan. So very, very classical study, already have last ASH longer follow-up. And again, very, very exciting and very, very remarkable data in terms of efficacy, right? What is really, really important about the trial is that this time-limited therapy. So it's providing to patients another alternative against patients that, because financial toxicity or because preference, they don't want to stay in a drug for life. So we know that this trial was designed to really provide 2 years of therapy and stop and wait until patient progress. So I think it's what's really, really bringing the opportunity for patients who, for many, many reasons, may or may not want to be in these long-term therapies to have another alternative. Right now, I'm always very, very interested to really follow those patients, because I think the prediction is very likely is going to happen as chemotherapy in the past. So high-risk population will start to relapse early rather than like a less high-risk population. We already saw that in the last follow-up, right? TP53, very interestingly, as we predicted, we're going to start to relapse shortly or like in less period of time compared with non-17P or non-TP53 after they stop therapy. Will those patients will be able to re-challenge with these therapies? Maybe the answer is yes. But we still need to know. We know chemotherapy select clones. We don't know very much about how Venetoclax is going to behave in terms of selecting clones. We know that it's equally effective in 17P, non-17P. So we may really see the disease coming back in the same way that was before. So it may be amenable to be retreated with the same drugs.
Well, you and I have interacted in the past in the treatment and clinical trials for chronic myeloid leukemia. And there, with the 4 agents we now have for initial therapy, one of the deciding factors of how we pick one are patient comorbidities.
Absolutely.
So can you discuss in the relapse refractory setting for CLL how things like cardiovascular disease, bleeding tendencies, being on anticoagulants might inform these decisions?
That's a great, great point. And as you know, Harry, we came from the era of CML. The more I really do CLL, the more I remember all the same problems that we have, we have and we still have with CML, chronic AEs, adverse effect, and really switching from one to another drug. There is no doubt is coming to the same answer I was telling you. Each patient is different. And now with all these different alternatives of therapy, I think we are in an excellent position to start to really offer the best therapy with the less potential side effects for each patient. You were bringing the story of the bleeding, of the anticoagulation. Of course, those things, they were never really a contraindication. We have done that. But in certain situations, you may really try to really look in another direction on drugs who may not really have this risk. Again, the risk-benefit should be discussed with the patient, and I think it's part of this conversation that we have with patients at the time that they require therapy.
So just give me some idea, what is the response rate in PFS with Venetoclax in the relapse refractory patients?
The relapse refractory data show very, very high rate of response, but it's less the response rather like at the PFS. We are really talking about 60%, 70% PFS over time. And I think the important thing, those patients, obviously over time, we're very interested to really follow. But the response rates or the progression-free survival is very, very related to the capacity of Venetoclax to obtain a minimal residual disease negative in the bone marrow. We know historically that from the time of the FCR, that the patient who really obtained this MRD negative in the bone marrow, they were associated with a very prolonged PFS. So the same thing is happening right now. The same thing start to evolve with Venetoclax. So I always say that Venetoclax is kind of chemotherapy without chemotherapy, but at the same time, we are able to really eradicate in a very, very high level the cells in the bone marrow, and these MRD negatives in the bone marrow very likely is going to predict, as happened right now and is being documented in Murano trial, very long progression-free survival for our patients.
And although Venetoclax is clearly active in 17p deleted patients, you don't need to have a 17p deletion or P53 mutation to use it. Is that-
Absolutely,
okay.
absolutely not. As you know, the initial indication for Venetoclax was 17p. Obviously, after that, it's been expanded, and right now, the recent label, the FDA is open for any front line or second line, and independently of the prognostic factors.